monitoring support of patients on watch and wait programs. So again, possibly historically we thought about this just in situations where people were diagnosed with MGUS particularly. So a scenario where relatively or almost exclusively a benign disease that has a 1 to 2% rate of transformation to myeloma per year. So the very vast majority of patients are not going to respond, but they have this big dark cloud hanging over them. So how do we manage that? What is the best way to manage that? But then also in a situation where we've got low risk, good response patients who are otherwise healthy and well, but they're out in the community, living life to the full, hopefully. But again, that dark cloud is still there. It's every time they go to hospital to get their paraprotein, there's that risk of relapse. So let's shine a bit of a bright torch on this and think about, what are we doing well, what are we not doing well in terms of monitoring support for patients that are not on active treatment at any stage of the disease. Do you want to kick off?
I have a lot of these patients because I don't like to commit my patient to treatment forever. So obviously they are anxious. The couple days before they come to see me, they're very anxious. So two things, sometimes we get the labs ahead of time and the patients can access their labs from home. They can go online and access their labs. The other thing you have to be, you can't sleep the night before. Give them something to help them sleep because they're going to be anxious. But the longer they smolder, the less likely they progress and the more comfortable they become. But you really need to understand that, the couple of days they're very nervous. I mean, you can't change that. Maybe you can, help them with some drugs to, adjust their anxiety, help them sleep the night before. But they always mention that. I don't know what else you can do except time.
Yeah.
And listening to them and acknowledge that this is a real phenomenon.
Sure.
I think it's difficult to avoid the fact that you have to monitor patients and therefore that has to be done at a regular time interval and that will cause anxiety. I think you can discuss with patients how that's going to happen. I think they need to be prepared for your paraprotein's gone up by 2, we're not going to do anything yet scenario in advance. I think that's very helpful for them to know what we're looking for and how we're going to act on it and what triggers there are going to be for us to change therapy or take more drastic.
So is this a potential group of patients, especially if they've got active myeloma but they're in long-term remission, that don't need to come to hospital to get checked up? I mean, is this not a classic cohort of patients that should stay at home and there should be some way in which they can interact remotely with hospital? Is that part of a new model of care?
I might be wrong. I think the vast majority of patients would say, so are you proposing they have a blood test at home and then phone up to discuss the result? So I think
or
that
the GP or?
So I think most GPs would not be comfortable to do that. For a patient who's been diagnosed with myeloma is in remission and follow-up, GPs are very reluctant to do that.
So GPs are very reluctant to take a blood test, to take a blood sample and send it to you?
Yep, because...
then you phone the patient with the result?
Oh no, that model works. Leaving the follow-up with the GP is not a model. And you can't expect them to have... So a GP will have one patient with myeloma and therefore don't have the confidence or the... and I don't think we should put too much on what we expect GPs to be able to have detailed conversations with their patients about, apart from anything else. But I mean, having a blood test in the community could be done without them seeing their GP.
Sure.
And then having a phone conversation is reasonable if they're well and don't want to. I think quite a lot of patients want to come and talk to somebody.
I get a lot of phone calls because a lot of autologous patients somehow. We have Angelo, who's our myeloma clinical nurse specialist, but for a window, but in the transition, I get them ringing me up wanting their results. And actually, I feel quite anxious about, I'll look it up. And it's great if everything is fine. But if there's an increase, I get anxious about, am I the appropriate person to be telling them this? And over the telephone, just because they're ringing up out of interest because they had a blood test 2 days ago when they had their Zometa, I feel very uncomfortable. I think it's a better environment is to be sitting down with the consultant.
So I prefer the model where a patient has a blood test in advance and then comes to have the discussion with the results with the
But
person
are
who
your
does feel
myeloma clinics
confident
not
to talk
bursting
about
at the
it.
seams?
Sorry?
Are your myeloma clinics not bursting at the seams?
Yeah, no, I'm not saying that has to be done in person, and it could be done, but it has to be timed right, I
But
guess. is the
just to push it,
importance.
but haven't we set that up? You know, the model that we have introduced our patients to, that's we've allowed them to put a trust in you, and it's like, so if you were going to, if you could have another model, so we bring people. I often say we take people and we bring them off the street and we turn them into a patient with cancer, with myeloma. But sometimes we're not very good at actually supporting them to return to some sort of normality, mindful of this watch and wait. And I'm just wondering, do you think that, for example, could nurses be doing these clinics? You know,
We had a good model at the Royal Marsden actually of having the vast majority of those patients on watch and wait follow-up seeing their myeloma specialist nurse for their
So
follow-up
they do
appointment.
this stuff.
They tend to be seen quicker and it's all a bit less.
Yeah. Okay.
involved, but-
Yeah, within our local hospital, I run a telephone clinic. Like every Tuesday, I have 15 patients, and some of the MGUS patients that we have, you know, the consultants, the ones paraproteins of 2 who are not smouldering, you know, they see them at when they get their diagnosis, see them again in 6 months' time, and then they discharge them back to the GP and get the GP to monitor their paraprotein maybe every 6 months. But the ones who are smouldering and who may progress, they're normally in my telephone clinic. I do it with another CNS as well. So basically, I have lots of patients who are stable, smouldering myelomas, CLLs, myeloproliferatives, MDSs, all of them really, because we set this clinic up because capacity in the clinics have been really quite bad. And so basically, I mean, the patients love it really because, I mean, they know me anyway. So, and yes, they are anxious to know what their paraprotein is, but I think if you like just tell them, you know, if your paraprotein goes up 1 or 2 points, you know, it's never going to be the same any one time that you take it. And then, you know, they have, we have like a questionnaire that we go through, and then if there's anything otherwise holistically they need help with, we support them. So, and we pick up as well, I've picked up a few patients as well who are progressing, so then, you know, they've had to have their scans ordered by the consultant, have liaised with the consultant, and then booked an appointment into their clinic. So it works really well. And I'm sure, like, if, you know, we could even have another clinic because our patient numbers are increasing and we've got no spaces in our clinics. And patients, they don't have to come to the hospital, they don't have to pay for parking. You know, the convenience at home, they know what time, we give them a time frame as to, you know, when they have their appointment. We'll ring, you know, we say about half an hour either way, but generally we ring them on time. So, you know, that's like 10 minutes, like on the phone, and then they carry on with their life and do what they want.
Yeah.
Yeah. Yeah, again, we could go on and on about this, but I think this is an area that needs a bit of research and a bit of, so one of the things Myeloma UK is working on is models of care, because I think there's lots of good examples of where it works, but I think all the points are valid, and then making sure that the right patient is in the right environment, and they also can move effortlessly between these environments if things change. And that's got huge implications for service design, for resources, MDT, pharmacy, etc., etc. But I don't think there's any question that we need new models of care. And I think there's an opportunity now for us to design them rather than somebody knock on our door and say, you need to do this by Friday, which is not unlike the NHS.